So I have the pleasure of introducing our next speaker. This is Dr. Cigdem Isitan Alkawadri, and she did her residency in neurology at Boston University, and she did her fellowship in multiple sclerosis and immunology at Yale. She has received multiple awards for teaching, and she is a brilliant and extremely busy MS specialist here at Magee. And you can go ahead. Okay.
Hello, everyone. I'm Dr. Isitan Alkawadri. Thank you for inviting me. It's a pleasure to be here. Today, we'll be talking about pregnancy and demyelinating diseases. We will specifically focus on MS for the sake of time and the relevance. But at the end of the talk, I'll be touching base on neuromyelitis optica spectrum diseases and pregnancy as well. MS is an immune-mediated disease that may result in physical, cognitive disability, and the reduction in quality of life. It can be a socioeconomic burden for our patients and families. It's one of the most common neurological diseases among young adults, typically starting around 20 to 40 years of age. Women are more affected than men, 3-to-1 ratio. And MS affects women of reproductive potential, so with pregnancy and birth outcomes becomes a major concerns for many patients, especially who are on disease-modifying agents. I'll start off with two patients of mine, and the first one, she's a 35-year-old female. She with a 5-year history of MS. She's been on interferon beta for many years now. Her last relapse was about a year ago. EDSS is 1 for sensory deficit. Her exam has not changed for the past year. She wants to become pregnant. My second patient, 32-year-old, newly diagnosed MS. She has active disease, the high lesion load and disease burden on MRI, active lesions, and she also wants to get pregnant. So we'll talk about these two cases at the end. Hopefully, going over some of the information will help us determine what's the best approach for both patients. But MS and pregnancy has been a topic of controversy for many years. And women with MS actually were discouraged from getting pregnant before 1990s up until the first large prospective study came out around 1998. And this changed drastically our counseling of women with MS. There are many disease-modifying drugs out there right now. It's coming out in the past 2 decades. But when used during pregnancy and lactation, there are beneficial effects for the mother, and the fears of concerning potential risks for the baby needs to be balanced. Patients have many concerns when it comes to this topic. They are nervous about if the disease affects their fertility, if they'll be able to take care of their child in case of worsening of disease, what are the possible side effects of the drugs on their baby, and they're concerned about the socioeconomic burden of the disease on themselves and the family. And as providers, we try to be with our patients along the way because they can get all the support and help they need in this process. There are 3 important steps we'll be discussing: the pre-pregnancy counseling, obstetric management and delivery, as well as postpartum considerations. But I can't emphasize enough the importance of teamwork-based approach. The care for our patients involve families, MS specialists, as well as their obstetrician, MFM, and IVF teams if needed, midwives, nurses, other doctors from different subspecialties. So it's a very big team that are actually there to help our patients along the way. At soon or after diagnosis, all women with MS of childbearing age should have a pre-pregnancy counseling, and I think this should be revisited at certain intervals, yearly at least, and particularly for a woman who needs to be or wishes to be on disease-modifying medications. And preferably, women with MS should talk to their provider prior to getting pregnant for planning purposes. And healthcare professionals should consider the benefits and risks of all disease-modifying agents, which we're going to go over in a little bit, and find the right pick for the patient, balancing the benefits and the risks. And we do recommend our patients in general to be on a contraceptive agent while they're taking the disease-modifying agents, and there is really no single no single type of contraceptive methods that we recommend, but we're going to go over that in a little bit in the next slide or so. And other thing to consider would be the MS and or drugs could have a potential effect in sexual dysfunction. So some of our patients may require assisted reproductive technology, IVF. So those teams are readily available if needed here as well. We do work very closely with our OB-GYN team here and anesthesiologists. Before all this, though, patients should be counseled in terms of the importance of vitamin D, taking prenatal vitamins, folic acid, avoiding alcohol and smoking, assuring good sleep hygiene, importance of low salt, low fat diet, leading a good, healthy lifestyle in general. Fertility is a main concern for our patients, and MS itself is not considered to reduce fertility, but some immunosuppressants used to treat MS may have a negative impact on it. There was actually a study published in April 2021, very recently. So they surveyed patients with MS, and they actually looked and found out that patients with MS had less wish and desire to become pregnant compared to general population, and the main reason cited for this one actually was the fear of not able to take care of their children in case of worsening MS, and also fears of the side effects of certain DMTs. So our patients do need a lot of counseling in regards to this aspect. As we were just talking about, there are many different options that can be offered to our patients in terms of contraception choice. Of all available techniques, long-acting reversible methods are the ones that we encourage the most based on the efficacy, safety, and convenience, but other options are reasonable too. There may be an increased risk of relapse after using a gonadotropin-releasing hormone agonist for assisted conception. However, this should not deter women with MS to seek ART if this is indicated. There was one prospective study including 16 patients, 26 ART cycles using the GnRH agonist, and they reported 7-fold increase in ARR after ART. And also imaging follow-up, this was within the 3 months of use of ART, did show increased lesions and active lesions as well too. A recent study pulled data from different cohorts report increased risk of relapses in the short-term period within 3 months after use of ART, both in agonist and antagonist, which I found interesting. So I think looking at the data, ART seems to increase risk of relapse with the findings we have, but the data is not clearly sufficient to say that this is contraindicated for MS. So neurologists should inform patients with this possibility. This is something we discuss commonly for our patients if this is the method that should be needed. This is the study I was mentioning in the beginning, the PRIM study, so pregnancy in MS. This was the first largest prospective study that aimed to assess the influence of pregnancy and delivery on MS. So in this study, 269 pregnancies in over 250 patients were involved. They followed these patients during pregnancy and 2 years after delivery in multiple European countries, and they reported that the annualized relapse rate actually found to be decreased during the pregnancy, especially in the third trimester, but there is a rebound and increased relapse rate in the postpartum period, specifically in the first 3 months. But the overall ARR in the pregnancy year, which we count as 9 months of pregnancy and 3 months postpartum, was similar to the pre-pregnancy rate. So there seems to be normalization there after this peak of an increased risk of postpartum relapse within the 3 months. No change of disability progression was observed during the study period. More active the disease in the pre-pregnancy year, and during pregnancy, the higher risk of relapse rate, which makes sense. And after delivery, MRIs were done in these patients, and it did show increase in new enlarging lesions as well as enhancing lesions. This, I think, this is quite important to highlight that we need to monitor our patients clinically and radiologically. But why is the pregnancy protective and there's increased risk of relapse postpartum period? There are different theories out there, but the most accepted one is the estrogen and other sex hormones tend to induce immunological changes by changing T helper profile to Th2, which is more of an anti-inflammatory as opposed to Th1. And the opposite seems to happen in the postpartum period. Therefore, it explains the increased risk of relapses that we see. I actually wanted to mention this trial. It was done on non-pregnant women with MS, but they looked into high-dose estrogen-containing oral contraceptives addition to subcutaneous interferon beta. And these patients had significant reduction in active lesions on brain MRI compared to those who received the interferon beta alone only. Needs to be taken with a grain of salt. We need more studies to confirm this, but I thought that was interesting to mention, and this could perhaps potentially further support the ideal protective effects of estrogens and other sex hormones in pregnancy. So patients ask me and they say, so what's my risk of having a postpartum relapse? Not every patient has a relapse after delivery. So there are certain things I look at, and the main things are the high relapse rate and disability prior to pregnancy, no history of DMT use 2 years before conception, which may point to the fact that patient may not have been adequately treated prior, obviously active pre-pregnancy MRI, and number of relapses during pregnancy. We need to consider all these factors. It's a new era right now, and there are new disease-modifying agents coming very often, which is exciting, but confusing at the same time for our patients because patients are not sure which treatment is right for them. And we talked about impact of pregnancy on MS, but what is the data in regards to the effects of MS treatment on mother and the baby, which is our patient's main concern? And how about breastfeeding? Can patients continue medications during breastfeeding? This is a long period we're talking about. And so population-based studies actually show that among MS patients who became pregnant, more than 40% were not taking the DMT prior to conception, 12 months prior to conception, which tells you that many women prefer to avoid risk of any drug-induced adverse outcomes for their fetus. It's important to counsel our patients with the knowledge we have in regards to this. The European Medicine Agency's EMA has a rating scale for drug pregnancy risk, and the FDA previously used ratings in a letter scale, as we know. This is actually changing slowly. Now with the newer medications, we don't see this letter category anymore, but we're seeing more of a risk assessment as well as kind of clinical consideration and data. But we're still using the letter category, so I wanted to kind of put it up there for us to remember. With that, we'll talk about the first medication, glutamate acetate. There are so many different disease-modifying agents out there, as I mentioned. For the sake of time, we won't be able to go over every single one of them, but I try to include the ones that we use the most. This is the only Category B medication. Available data suggests that the branded glutamate acetate is relatively safe to prescribe during conception period and breastfeeding too. Actually, the pregnancy contraindication was removed from the EU label in 2017. We do have a good amount of data in regard to glutamate acetate. Over 20-year period, 7,000 pregnancies information were collected, and the rate of pregnancies resulting in congenital abnormalities exposed to glutamate acetate while pregnant was actually pretty similar to the European EuroCat database and US populations too. I think this is a reassuring data for us. Different types of interferon beta out there. Category C, there isn't evidence of possible increased risk of lower birth weight and preterm birth. However, the data from patient registries suggest that exposure to interferon beta early pregnancy time perhaps does not have an adverse impact on pregnancy outcomes. The previous concerns around the spontaneous abortion and congenital malformation are actually associated with interferon, but they have not really been seen in larger registry studies. So since 2019, EMA actually suggested continuing interferon beta until conception, during pregnancy, and perhaps during breastfeeding as well too, and can be used during breastfeeding because of its high molecular weight. Teriflunomide is our only Category X medication. Women wishing to conceive who have received teriflunomide should stop it and undergo an elimination procedure. Patients must use effective contraception while on this therapy and 2 years after stopping the medication unless they've gone through the accelerated elimination process. Men should be advised as well if they're taking teriflunomide. It could reduce sperm counts, and male to female transfer of sperm may result in low levels of the drug being present in the female. It's a small molecule, so it's not recommended during breastfeeding. Fingolimod is our oral medication, Category C. There are previous reviews report evidence of spontaneous abortion, organ defects, but the data in human is limited. We do recommend fingolimod to be discontinued before conception and perhaps maintaining contraception for 2 additional months after discontinuation. Excretion in human breast milk is still not known. We don't recommend breastfeeding while taking fingolimod. This is the most important part, I think, about fingolimod, because for whatever reason, when you switch a patient from fingolimod, could be for pregnancy or DMT failure, patients do have an increased risk of relapse, which we call as a disease rebound risk. And patients should be notified about this. Physicians should be prepared about this. As patients who relapse during pregnancy, initiation of high-efficacy disease, DMDs, soon after delivery is advisable, usually to prevent postpartum relapses. So breastfeeding may not be recommended for these patients, but again, decision needs to be made on a case-by-case basis. There was a retrospective study done and conducted in 4 Italian MS centers. They actually reported that relapses were observed in 22% of patients during pregnancy and 44% in the postpartum period. And also along the same line, compared with radiological assessment before pregnancy, more patients had new enhancing lesions after delivery. Dimethyl fumarate is another oral DMT. It's a Category C medication. We do recommend it to be stopped before conception or right after. It has a very short half-life, so no washout is required usually. It's a small molecule. We do not recommend breastfeeding while on dimethyl fumarate either. Data regarding natalizumab is interesting. So it's a Category C medication. It is recognized to have teratogenic effects in animal models. Human studies are lacking. Prospective studies evaluating pregnancies exposed to natalizumab raise concern, perhaps increased rate in spontaneous abortions. There was a case series published in 2014. They described pregnancies in 12 women who were treated with natalizumab in the 3rd trimester, had healthy newborns. However, they had mild, moderate hematological changes like anemia, thrombocytopenia. So there's a preliminary evidence suggesting that hematologic abnormalities may be lower in newborns exposed to natalizumab for less than 30 months as opposed to more than 30 weeks, so suggesting perhaps the withdrawal of natalizumab around week 30 may be the preferred option to both protect baby and the mother. It is not recommended to use during breastfeeding, and there are 4 different approaches actually in regards when it comes to Tysabri. So the conservative approach is discontinue the medication before conception, maintain effective contraception for about 2 to 3 months after discontinuation. Semi-active, maintain the medication at least until conception, but restart right after delivery. The active approach, which is being used more and more commonly for patients who have active disease, maintaining the natalizumab until 34 weeks of pregnancy, and then stopping to prevent adverse outcomes in babies, and then restarting perhaps after delivery to decrease the rebound risk or disease rebound or risk of relapses after stopping the natalizumab. And there is the last approach, is the bridging approach. This is still being debated. So shifting natalizumab to a B-cell depleting agent is being considered. However, again, the data is quite lacking in this regard. Alemtuzumab is a category C medication. It is recommended to be discontinued before conception, and women should maintain contraception for additional 4 months after discontinuation of the medication. Women should be informed about the possible drug-induced risks in regards to autoimmune thyroid diseases, ITP, good pasture, other autoimmune diseases. But specifically, alemtuzumab-induced thyroid disease can be associated with fetal effects such as MR, dwarfism, and increased risk of miscarriage. Women should be counseled in regards to that. Orcolizumab and rituximab, in other words, B-cell killers, are anti-CD20 agents, are being used quite often, commonly these days, but there is really limited data in regard to use of ocrelizumab in pregnancy. In animal studies, administration of ocrelizumab throughout the gestation was correlated with kidney problems, decreased testicular weight in offspring. The most commonly reported effect would be the peripheral B-cell depletion and lymphopenia. This is mainly from the studies in regard to rituximab. In 2019, a prelim data from a study investigating over 260 pregnancies of MS women exposed to ocrelizumab. This was exposed to ocrelizumab here was considered as if the last infusion occurred within 3 months of conception or during pregnancy, and the study did not reveal an increased risk of negative pregnancy outcomes, but still ongoing. We need more data in regards to this. And that's why there's no one single answer when should the patient start conceiving after last infusion. In Europe, it is after 12 months. Here in US, FDA advises 6 months. In practice, it's somewhere between 3 to 6 months because of the after that 2019 data, but should be discussed, I think, on a case-by-case basis. But patients should remain on contraception while on these agents until they wish to become pregnant. How do we treat relapse during pregnancy? Patients should avoid corticosteroids if possible in the first trimester due to risk of fetal malformations. Short course of high-dose methylprednisolone could be considered in second and third trimesters. And for patients who are not responding to steroids well, Plex could be recommended if the benefits are outweighing the risks. Symptom management gets very complicated during pregnancy because yes, we did mention many women have improvement in their symptoms and decreased relapse rate. However, some symptoms worsen, such as fatigue. Patients may have, increased numbers of UTIs, numbness, tingling, carpal tunnel, myalgia, paresthetica. These can be commonly seen in pregnancy, but it could be confused with a relapse during pregnancy. So what I recommend my patients usually that they should tell me any new or worsening symptoms they have and their OB-GYN as well, so that we kind of help them walk through the process and help kind of tease out and differentiate. Peripartum depression is an important topic because some of our patients already have baseline depression, and this could get worse with pregnancy, delivery. Certainly patients should be counseled in regards to this. And this is another topic, and I had long conversations with our anesthesiology colleagues over here in regards to this. And historically, MS considered to be a relative contraindication to spinal anesthesia, but we don't have great data. The reason for this, understandably, because of the neurotoxicity or concern of neurotoxicity of the anesthetics for patients who have especially spinal cord lesions, demyelinating lesions. But there is lack of recommendation. So from the available data, we recommend that MS should not influence the mode of delivery or analgesia, anesthesia, unless there is significant disability where the patient need to have an assisted vaginal delivery or C-section. That we usually leave it to our obstetricians and anesthesiologists consideration. Women with spinal cord involvement or loss of sensation below T1 may not be aware of the onset of labor, so they should be taught to look for other symptoms indicative of onset of labor. I think that's very important to counsel our patients. In terms of type of anesthesia, I get asked this question too sometimes. So in the PRIM study, 42 patients underwent epidural analgesia, and there was a trend towards higher ARR in the 3-month postpartum in patients with epidural analgesia, but then the difference was not statistically significant. In the Italian pregnancy study, they included 350 pregnant women who received epidural analgesia without any increase in the AR 1 year after delivery in close to 20% of patients. So recent studies show that there was no difference in the frequency of use for different types of pain management between women with MS and general population, except perhaps in multiparous women with MS who were more likely to have the epidural analgesia than were healthy women. The impact of pregnancy on the long-term disease course and disability is not clearly identified, yet it's thought to be benign. So 8 studies suggested that pregnancy has no effect on long-term outcome in MS, whereas 4 other indicate that perhaps parity was potentially beneficial. Studies are limited, but I think it's reassuring for our patients to know that the total number of pregnancies in an MS patient's lifetime did not appear to have a negative influence on the long-term course of the disease. The debate continues with the breastfeeding. The benefits of breastfeeding to the baby mother has been clearly established, but in MS, this general recommendation is challenged by the fear of reappearance of the relapses. Patients want to get back on their medications right away after delivery, if possible, to help prevent relapses, manage their symptoms, and so they can take care of their babies. So this is a challenging topic. In the PRIM study, no difference was found in IRR in the first 3 months postpartum between 87 women who did not breastfeed and those who did for any duration. But then women who chose to breastfeed had a lower relapse rate before and during pregnancy, which may have introduced a bias there. In a Finnish study of 61 women, breastfeeding was less frequent and shorter in duration among mothers with active pre-pregnancy disease, which makes sense. In terms of management of postpartum relapse, there is really no indication to stop breastfeeding actually if methylprednisolone is required for a postpartum relapse. There's no evidence also to support a regular methylprednisolone use in the postpartum period to prevent relapses. Data on IVIG is a bit conflicting. Some studies suggest reduced frequency of MS relapses, and possibly slowing the disease progression during pregnancy with regular monthly IVIG use, and some conflict the results. In general, we don't routinely recommend postpartum methylprednisolone or IVIG. However, I think this should be evaluated on a case-by-case basis. For instance, I'll give you an example. I have a patient who has MS, she has stable MS, and she's on one of the injectable medications, and she just delivered her 4th baby, and so this was a kind of counseling for her 4th pregnancy. She only had relapses postpartum, and so obviously she was fearful to have another relapse again. So this is a patient I recommended a prophylactic IV methylprednisolone in the postpartum period, and again, I think this should be like the approach on a case by case. And for patients who have higher risk of relapse after pregnancy, this is something we recommend as well. So going back to our cases, so let's talk about these 2 patients of mine. So first patient, she seems stable. She did not have a relapse over a year now. EDSS is mild. Sensory only is 1. And she wants to become pregnant. There's no reason that she shouldn't. Do you continue interferon or not? I think it's optional here. She chose to not continue action. I was okay with that. Her MRIs have been stable. She was clinically stable. She delivered a healthy baby, and she continued to breastfeed, but she did continue her interferon at that time. And so other patient of mine who has an active disease of MS, and she has high lesion burden, spinal cord lesions, with active enhancement. So this patient has active disease and needs to be treated ASAP. So I do obviously respect my patient's wishes, but I need to tell them what I believe is right. And so what I told this patient was that I kind of put the information out there for her, and I did tell her that I think it would be best and safe for her to perhaps get the disease under control first for about a year, which is exactly what we did. And she was placed on a high disease DMT, and MRIs were stable. She was clinically stable. She became pregnant after that and delivered a healthy baby. And she was initially thinking about breastfeeding. Now she decided not to. And we were able to resume her high efficacy DMT afterwards. So I think the most important take-home point from here would be the planning for our patients. So we should talk to our patients and reassess this at regular intervals in terms of their pregnancy wishes, and so we can plan accordingly with the data we have. We should reassure our patients that MS per se will not affect their pregnancy in the long run, and we should talk about the benefits and risks of the different DMTs that we have available. And also, patients should be educated, physicians should be prepared regarding the potential rebound risk of some of the DMTs that we mentioned, such as fingolimod and natalizumab. It's my last slide. The data is even less about neuromyelitis optica spectrum disorders and pregnancy. As we know, the female-male imbalance is much more pronounced in NMO than MS. If not treated properly, NMO has much higher rate of morbidity and mortality than does MS. Data is very limited in regards to pregnancy. But some of the studies I found, some studies reported no modification of disease activity during pregnancy in comparison with the pre-pregnancy year, but the relapse rate seems to be increased during the postpartum period. NMO spectrum disease may be associated with higher risk of miscarriage itself, which is not something we've seen with MS. The one study reported a substantial decreased postpartum relapse in women who were treated with steroids and azathioprine and maintained throughout pregnancy, and for patients who were treated with immunotherapy before pregnancy. So I think the take-home point from here, again, preparation, talking about patients' wishes and kind of balancing the benefits of the medication for the mom and the potential risks and adverse effects for the baby from the DMTs that we have. That's all I have. Thank you for listening, and happy to get any questions you guys have.